Good morning, ladies and gentlemen. We are the Group 8 senior clerks of the Cebu Institute of Medicine. Today, we welcome you to our clinico-sociological case conference entitled Katig, a webinar on hospice and palliative care. Before we officially begin, may I request everyone to please put ourselves in the holy presence of the Lord as we begin with a prayer.
Heavenly Father, at every moment of your existence, you are present to us. God, in gentle compassion, help us to be present with one another so that our presence may be strength that heals the wounds of time and gives hope that is for all persons through Jesus, our compassionate brother. Amen.
Every boat has its journeys. Oftentimes, the open waters of life become too turbulent to be traveled alone. Katig, or outriggers, are stabilizers used by the Philippine Bangka to enable a simple boat to brave even the most violent of open seas. In the troubled waters of sickness and suffering, as people near the end of their journey, we physicians can be their Katig.
There is a disease that every physician always looks out for and hopes and prays that his or her patient doesn't have it. The dreaded C word, cancer. Like the unpredictable waves of the treacherous sea, it destroys everything on its path. Day after day after day, the lucky ones make it, but most aren't so lucky. This is especially true in the Philippines, where the current state of healthcare leaves much to be desired. Many of the poor do not even get to see a doctor in their lifetime. This is the story of Esther Anga, a 50-year-old married woman who is currently unemployed. She lives in Alang-Alang, Mandaue City, Cebu, in an area that qualifies as a slum, along with her husband Arturo Anga, who is also formally unemployed and does odd jobs around the neighborhood to make ends meet. This nets them around 500 pesos a day when he is able to work, but their income is unreliable at best. Esther Anga is currently bedridden, has an increased abdominal girth, and has undergone wasting, making her arms appear to be just skin and bones. She also suffers from edema of both legs, along with severe leg pain. Having no children, Arturo is her only care provider, so he has to divide his time between taking care of his wife and looking for money.
Ka, nakay lakaw ron?
Wala raman, pero gawat palagi ko tawag sa mga kauban kay nabay aksa sa kumpanya ba?
Esther's disease all started 3 years ago when she was able to avail of a free checkup with an obstetrician gynecologist. A whole abdomen and a transvaginal ultrasound were taken and showed that Esther had a uterine myoma, a benign mass in the uterus. She was advised for operation but declined due to financial constraints. One year later, she experienced a sudden onset of dull, persistent hypogastric abdominal pain with a pain score of 3/10, along with a gradual increase of her abdominal girth. She also noted a round, smooth, slightly elevated abdominal mass on the right lower quadrant of her abdomen, which was bigger than a tennis ball. Esther has also observed that she was slowly losing weight, noting that her clothes have begun to feel looser around her body. This prompted the patient to consult a private physician, where she was advised to take unrecalled medications, which included mefenamic acid for pain. After another year, the hypogastric abdominal pain worsened to 8/10, and her abdominal girth slowly increased, prompting another consult with the same private physician, where the same management and medications from the previous year were advised.
Ga murag kabantay ko ba, murag nidako lagi mong tiyan. Murag kag kanang di mga buwan nga mapdos ba.
Huwag bitaw ga, no? Pero, minupos naman ko ga.
Basin milagro di ay.
Kasi may lagrong mga anak diya ga. Uy.
Basin di ay.
Ay, pero ga, naapi taw dugo usahay?
Ha? Kanang murag regla?
Oo, murag regla niya. Naikuyog nga sakit sa akong tiyan.
Murag angay man siguro na magpa-check up na ang katahana.
Ang saga eh. Isot ka yung kwarta karon.
Sa bitaw.
After 4 months of enduring her symptoms, they sought consult due to the persistent abdominal pain. A transvaginal ultrasound was again taken, which revealed an enlarged uterus suggestive of a submucous myoma and a pelvic-abdominal cystic mass, which was likely an ovarian new growth, with a high risk for cancer. She was advised for immediate surgical intervention, but again, due to financial constraints, she declined. 1 week after the ultrasound, she noted swelling of her left thigh, which progressed to her entire left leg. Thereafter, her right leg followed. She noted severe pain in both her legs with a pain score of 10/10. She consulted in a private tertiary hospital, where it was explained to her that her mass was possibly compressing her blood vessels, thus causing the edema. Their clinical impression was a possible cancer with metastasis. Surgery was again advised, and again she declined due to financial constraints. Another month later, due to the persistence of the pain and swelling, with a further increasing abdominal girth, they decided to seek consult in a DOH-certified Apex hospital. A CT scan was done, which showed the following: a lobulated heterogeneous abdominopelvic mass with the largest diameter of 19 centimeters, with associated metastatic nodes extending beyond the abdomen, with multiple metastatic lesions in the liver and right kidney. Multiple uterine myomas were also noted. She underwent the following managements: blood transfusions for anemia, left ureteral stenting, explore laparotomy, adhesiolysis, removal of periumbilical mass, and total abdominal hysterectomy, bilateral salpingo-oophorectomy. She was discharged with a final diagnosis of nulligravid ovarian new growth, serous cyst adenocarcinoma, right ovary, stage 4B. She was advised to follow up for further treatment but was not able to do so. On further investigation of her biopsy, it showed right ovary, high-grade serous cyst adenocarcinoma with multiple tumor-positive areas. After 2 months, the couple decided to consult at the Cebu Institute of Medicine Community Medico-Social Services, due to persistent swelling and pain in her legs. Pain was described as non-radiating gnawing pain with a severity of 10/10. She was given furosemide for the swelling, tramadol and pregabalin for the pain, with backup morphine sulfate. Esther noted partial relief of her symptoms. Not too long after this, a home visit follow-up was done on the Anga couple in Alang-Alang, Mandaue City, Cebu. She was noted to be asthenic, jaundiced from the head down to the thighs with icteric sclerae, along with multiple enlarged lymph nodes in her neck area. Her abdomen was protuberant with a circumference of 90 centimeters and a palpable, tender 6.5 centimeter mass 10 centimeters from the right costophrenic angle. There was also a 24 by 22 centimeter periumbilical mass noted. Her legs were noted to be edematous, with bilateral moderate grade 2 pitting edema. Our diagnosis for Esther is serous cystadenocarcinoma, right ovary, stage 4B, with recurrent progressive disease.
Ovarian cancer. A quick infographic can save your life and the women around you. Ovarian cancer is the fifth leading cause of cancer-related deaths in women and the second most common cause of death from a gynecologic malignancy. Ovarian cancer targets mainly the ovaries, the organs producing the women's egg cells. Like any other cancer, there is an uncontrolled growth of cells within the organ, and these cells have a high chance to metastasize or to spread throughout the body. Signs and symptoms of ovarian cancer are usually not direct and most often occurring late. These are abdominal pain, abdominal fullness after eating, fatigue, back pain, irregular menstruation, difficulty eating, and many more.
Any diseases, you have to, as much possible, you have to look it as one disease. That's why your presentation of ovarian, of pelvic mass, of leg swelling, those are part of the disease. Those are not different disease. Those are just what we call progression of the disease, or progression of the disease.
That leaves us to ask, as a woman, am I vulnerable? What makes me at risk for ovarian cancer? Risk factors associated to ovarian cancer are elderly women, women who had menstruation earlier than 12 years old, women who had menopause later than 52 years old, women who has never been pregnant, women taking estrogen pills, and a family history of ovarian cancer.
As mentioned, probably low parity or newly gravid, or probably family history of breast ovarian cancer, or ovarian cancer. So those are the things. But usually, 80% or 90% of the time, this is what you call sporadic development, meaning there's no clear-cut risk that the patient develop.
Unfortunately, ovarian cancer has no screening tool for most well-appearing women. However, imaging through a pelvic ultrasound can help, but is only diagnosed through a biopsy where tissues of the ovaries are seen through a microscope.
In all cancers, if you were able to see the patient early, then the chance of survival, the chance of this disease to be caught in the early stage will be far better and will have a good prognosis. The problem with ovarian cancer is that we don't have a screening test for ovarian cancer. It's not like cervical cancer, you do pap smear. So endometrial, ovarian don't have screening test. The problem with ovarian cancer is that it starts in the abdomen, and the abdomen is spacious area. So when it starts, it doesn't have symptoms. When it has symptoms already, you can feel already there's a mass, there's obstructions, there's already GI problem, there's already weight loss, early satiety, gas pain. All those are signs already of advanced disease. So about 70% of patients with ovarian cancer will be seen in an advanced disease like stage 3 or stage 4 because of the there's no screening test, and of the location of the disease.
Staging an ovarian cancer can help guide the medical team. Stage 1 is defined by the cancer only seen at the ovaries. Stage 2 will be defined by the cancer seen limited on the female reproductive organs. Stage 3 is when the cancer has spread in the abdomen. Stage 4 is when the cancer has spread to the different organs throughout the body, such as the bones or the liver.
Unless if you have high risk, if you have family history of breast cancer or ovarian cancer, then you have to have early checkup. He noted that it's not ideal screening test because we don't know how fast the ovarian cancer develops, so it's not part of the screening test. So we cannot recommend to have a regular pelvic exam every year because it doesn't prevent ovarian cancer.
Treatment of ovarian cancer vary according to the extent of the disease and the state of the patient. There are surgical options where the tumors or the organs are removed. Chemotherapy and radiation therapy are also utilized to essentially shrink the cancer. And if the cancer is advanced, hospice and palliative care is an option to maximize patient comfort.
So considering usually in this time of pandemic, we see the overall picture of the patient. If the patient can survive the disease or can what you call can take the management like the major operations. So usually there are criteria that we see for management of surgery. If there is what you call primary debulking surgery or what you call neoadjuvant treatment. So considering she has already distant metastasis on CT scan, usually what we do is what you call we do biopsy first to make sure that this is cancer, then give neoadjuvant chemotherapy. The purpose of neoadjuvant chemotherapy is to shrink the tumor, to build the nutrition of the patient, and to lessen the morbidity during the operation. And during that time, if the patient, the tumor is shrink already to a smaller size of our operative size, and the patient is, the nutrition of the patient is built already, then you will the morbidity, complications, bowel resections, blood loss is much lesser. So the usual ovarian cancer is the more what you call basic ovarian cancer is the epithelial type like endometrioid or mucinous type. All those are what you call standard ovarian cancer. But once it is labeled as serous carcinoma or clear cell carcinoma, these are what you call highly aggressive type of tumors.
Unfortunately, since most cases for ovarian cancer are found late in the disease progression, usually after metastasis, the prognosis for such cases are poor. For stage 4 ovarian cancer, only a few women can surpass 5 years survival.
It is always difficult to give bad news to a patient, so it is helpful to have a strategy in place to make breaking bad news just a little bit easier. By putting the patient and their family at ease, you, as a physician, can be more at ease as well. Spikes is a mnemonic that will help you set up good interaction with your patients. S stands for setting, which involves making sure you have a quiet location for your patient and reducing distractions that will come up during the interview. P stands for patient perspective. This has to do with asking what the patient's current understanding is of their current situation and what they think is the reason for having this meeting today. I stands for invitation for information. Ask if they want to hear more about the treatment or further details about the diagnosis. Bear in mind, some patients may opt not to be told about certain information. K stands for knowledge. This means you should talk to the patient at their level of knowledge. A physician should recognize that patients do not have all the medical knowledge and training the healthcare providers receive. E stands for explore emotions and empathize. This is one of the more critical things you need to do as a clinician when expressing bad news. It's important to be aware of the verbal and nonverbal emotional expressions shown by your patient. S stands for summarize. Summarizing the conversation is important. This makes sure your patient walks away with good understanding of what you told them at the meeting.
Ay, ma'am.
May buntag, ma'am. May buntag, sir. Pero, katong nagstorya mo sa doktor, sir, unsa may imong nasabtan adto sa iyang istorya sa imo?
Parte siyang sakit kung siyang saktan. Ang parte sakit niya, ito lang sa pag-operasyon niya sa ako yung mayoma. Mayoma, kung nailang ng pukul-pukul, military sa kuwan, o tigi, panguha. Kaya cancer naman siya.
So, nasultian dito yung mga cancer dito siya.
Sa soto na ba? Sa soto pa lang ba?
Ma'am, Esther, okay ra nimo makahibaw pa sa resulta sa imong biopsy?
Biopsy ba?
Sa resulta, na naman yung resulta sa biopsy nimo to sa una na wala ninyo nakuha. Okay ra nimo makahibaw ka sa imong kondisyon karon? O sir, gusto unsay ganahan nimo mahibaw-an? Na gusto mo ma-explain unsay itong pasabot sa biopsy? Ganahan mo makahibaw unsay pasabot ato sa iya resulta? Sige. Okay ra nila.
Na mauto siya ni kalat sa tiyan mo na tiyan mo sa sakit sa atay mo tong naiuban laboratory test no nga basig mahibong ka nga mga resulta kay kanang dili wala sa normal nga range unya ni kalat siya sa base sa CT scan na posibilidad nga sa bukog sad mo ng sakit ug dito sa iyang mga lisay-lisay mao nang naghupong si ma'am. So mao na siya ang amo ang nakit-an sa mga laboratory test, sir.
Okay, thank you, no?
So, base sa kanang agresibo naman gud ang type ang sa cancer ni ma'am sir niya kanang stage 4 ang ovarian cancer ang kanang nakasuwat sa kanang biopsy no nya kung kani nga kanang type nga kanang sa cancer kay ang plano na lang ang plano jud ani kay katong palliative bitaw sir kibaw ra tanang palliative
Palihog lang kog explain sa nang
so kanang palliative sir kay paningkamutan na to ana nga medyo maalibyo bitaw si ma'am sa kanang sakit na iyahang na bati ana sir o ang kuan ta ato kay katong chemotherapy o katong opera pero murag agresibo naman good sir ba nya ang mabuhat nato matud sad sa ato ang mga specialist na ato ang kasturya kay katong palliative sir kung cancer gani kanang agresibo na nga type
o comfortable siya unya dili lang sa ni siya sa physical sir sa iyahang emotional no ato sa atimanon iyahang kailangan na emotional kung na siya mga ganahan mga request katong niingon ka ganiya sir no nga na siya ganan kanon sa na nato mga tag ni ma'am no unya kung dili sa ganan si ma'am kaon dili sa nato pugson no dili gyud siya ganahan kaon unya sa iya sang mga kinahanglanon nga spiritual no ang pag-ampo o kanang pakuan na ba ni siya sir kanang paghilog
taga-muan taga salamat kung dako Diyos sa inyong tulog.
Para dun mi diri maminaw nimo sir.
Sige lang sir, ipagawas ra na sir.
siya gusto ng
Ako rin, salamat yung ma'am. Yung tulong na mo. At kami wala magkatong na. Tingnan Nari ka. Napalili ka pa nga mo. Nakakurin ka mo sa akong asawa. Nasambatigan mo ko na yun, ma'am. Dili gumigyan, ma'am. Hindi may hutang na yun ang sitwasyon. Itong tabang. Salamat kayo, ma'am.
So, naingon naman nila na murag wala na tayo mabuhat para sa kuan, sa cancer ni ma'am ug sa bukol. Imposible na jud siya matangtang karon kay katag na siya sa lawas pero dili pa sabot na wala na tayo mabuhat para ni ma'am. Buhaton nato na ang kadang mga nabili niya na oras diri sa kalibutan, di siya kaya magsakit. So mao na kanang ato siya pakanon kung sa iya ganahan, kanang mga bawal-bawal murag kalimtan na nato kanang mga bawal na pagkaon ato siya pakaunon ato mga prutas iyang ganahan niya.
Gatas na anlin. Unsa pa? Chocolate or vanilla?
Mga hilig ni mo, ma'am.
Prutas. Utan. Prutas? Unsay prutas? Prutas. Okay. Unsay prutas imong favorite? Grape. Apple. Orange kuno. Pwede ba daw orange, guys?
Sa
Hospice and palliative care, as defined by the WHO, is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses, through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual.
Palliative care is an approach that improves or maintains quality of life. Patients who have life-limiting or life-threatening illness. Mostly, our patients are cancer patients. Basically, mga kuan siguro 95% or more. But we do not limit our patients to cancer alone. We also cater to chronic end-stage renal, chronic end-stage cardiac, pulmo patients. We even have patients with motor neuron diseases like ALS. And we also have patients who are HIV patients, HIV who progress into AIDS. We also have patients who are with severe dementia.
There are a total of 4 goals in hospice and palliative care. The first goal is to provide relief from pain. Pain is the most common symptom in palliative care and is defined as an unpleasant sensory and emotional experience. Palliative care aims to address the pain and to allow patients to take control of their situation and be alleviated from pain. It requires an accurate and detailed assessment of the pain. The analgesic ladder serves as a guide in the choice of drugs to be used. The first step is targeted towards mild pain or those with a pain score of 1 to 3. In this step, non-opioid analgesics such as non-steroidal anti-inflammatory drugs or acetaminophen are the drugs of choice with or without adjuvants. The second step this time is meant for moderate pain or those who complain of 4 to 6 on the pain severity scale. Patients at this step are provided with weak opioids such as hydrocodone, codeine, or tramadol, with or without non-opioid analgesics and with or without adjuvants. Now, if patients have a pain score of 7 to 10, this is identified as severe pain, and they are then on the third step of the analgesic ladder. Patients with severe or persistent pain are prescribed strong, potent opiates, such as morphine, fentanyl, oxycodone, or hydromorphone, with or without non-opioid analgesics, and with or without adjuvants as well.
And our aim really in palliative care is comfort. Relieve the distressing symptoms of these patients. and pain management remains to be the pillar in palliative care. You have to enumerate based on the most distressing and the least distressing. So number one yeah, is pain.
The second goal is to maximize the patient's quality of life. It is important that patients still feel comfort and peace.
So kung ganahan siya, aking pasyente nga ganahan kay makauglit o kana. So kung ganahan siya, kung mawish siya sa pasyente, ganahan siya nga di na magpakuha mga vital signs, okay ra kaayo. Okay? So ganahan siya mo kaon kung unsa even though restricted siya, okay ra kaayo. So as much as possible, let her enjoy.
The third goal is to provide psychosocial and spiritual care for the patients throughout this difficult process. Psychosocial distress is often described in terms of anxiety and depression, and expressing feelings such as denial are best regarded as manifestation of coping mechanisms. Counseling, support, and pharmacologic treatments are all part of the palliative management. Spirituality encompasses the purpose and meaning of an individual's existence. There should be unreserved respect for an individual's religious beliefs and practices.
Okay, situation, family support, financial support, okay, or if the patient has a family history of depression or psychiatric problem, okay, so it's also a big factor, okay, that this patient would easily go into depression. Okay, it's a case-to-case basis, and it would really depend. When you manage this patient, it's really different when as compared to managing a purely IM patient, purely OB patient, that. Okay, so it encompasses the physical. Okay, so we have to deal with the emotional, psychosocial, and even spiritual, and we also have to deal not just with the patient, but we have to deal with the family.
Family support is the cornerstone of the fourth and last goal of hospice and palliative care, as patients are striving to live through each day, fighting through all manner of pain.
As part of a hospice and palliative care intervention to the patient, you should properly break the bad news to the patient. When we properly disclose the bad news, I think we have to schedule a family meeting. Next discussion, after the discussion of breaking the bad news to the patient that it's already a progressive kind of a cancer, is discussing the goals of care. So these are the important discussions that you have to also talk to the patient or the family. Whether the patient still wants to be admitted in the hospital with all the aggressive measures, or the patient just wants comfort care.
Their families and their caregivers are also going through their own constructive pain and suffering.
These caregivers, so as what I mentioned, irritability during the care, and sometimes they will be easily get sick. Okay, sometimes, and because of the frequency of the care, okay, because of the lack of sleep, okay, their immune system will be down. Okay, so as much as possible, we have to adequately assess for that and other symptoms. We just have to tell, okay, the husband maybe, okay, or the caregiver that we are here, okay, anytime if they have problems or concerns, okay, they can contact us anytime.
The message of palliative care is that whatever the disease, however advanced it is, whatever treatments have already been given, there is always something which can be done to improve the quality of life remaining for the patient.
With COVID-19 having brought upon nothing but limitations and restrictions, Ma'am Esther is just one of the many, many patients who had to bear their condition and sulk in the pain, as their disease progressed to an end stage right in front of their eyes, all as the pandemic has prevented them from acquiring conservative and conventional interventions.
Basically, the pandemic brought havoc to the management of all diseases. Okay, so what happens is that the patient cannot have consult because most of they prioritize all management, all ER or all consult to be an emergency. Second is they have fear that they might get COVID if you go to the hospital. Third is the doctors have uncertainty already to see patients. There was delay in all management of diseases, including cancer. The problem with cancer is that the cancer doesn't mind about pandemic. It doesn't wait until the pandemic ends. So that's why most of the patients we see during this time of pandemic are already advanced disease because of the late management, late consult, or late availability of operation. During the time of pandemic, there was nobody were allowed to operate because they have to prioritize all resources for COVID cases.
One of the programs of the Department of Health is the Philippine Cancer Control Program, which is included in the National Cancer Prevention and Control Action Plan 2015 to 2020. The program has a mission to reduce the impact of cancer and improve the well-being of Filipino people with cancer and their families, and a vision of a comprehensive cancer care and optimized cancer survival in 2025. These are the objectives and goals of the program. Some of the specific cancer programs are headed by the Philippine Cancer Society, Ramon Abartes Foundation Incorporated, the Hepatology Society of the Philippines. In the Philippines, 34 organizations provide 108 hospice and palliative care services. Alongside these providers, a wide range of groups give compassionate care to the dying.
Please make this Christmas bright. And your favorite dream on a star. Wish upon a Christmas night. Sing about the better things of friends we had, the joy they bring. Hang a dream upon a star and wish.
Hi, this is Shara, and alongside with Dixie, we will be tackling the PFC matrix. So Dix, what is the purpose of this PFC matrix?
Well, Shar, the PFC matrix is an approach to get to know our patient in a holistic manner. It is divided into 3 parts: patient-centered, family-focused, and community-oriented, which we will be individually discussing as we go along. Each approach is divided into 4 components, which include data gathering, analysis, assessment, and management for each approach as shown in the table.
Under the patient-centered approach, this utilizes the interplay between biomedical and psychosocial factors in order to implement management that is tailor-fitted to the needs of the patient. So for the data gathering, the biomedical history and physical findings show that our patient is a 50-year-old female who noted an increase in abdomen for the past 3 years and had postmenopausal vaginal bleeding last March 2020. There was also noted abdominal pain with a palpable tender mass, as well as lower extremity pain and swelling up to the thighs, leading to inability to walk. Other pertinent physical findings include jaundice down to the thighs, icteric sclerae, palpebral conjunctivae, oral mucosa, and palpable neck lymph nodes. Psychosocial issues include being dependent on husband for activities of daily living and a fear of approaching certain healthcare professionals regarding the current condition. For the analysis, the biomedical history and physical findings revealed that there was persistence of symptoms for over 3 years with partial relief from prescribed medications. Analysis of psychosocial issues showed poor health-seeking behavior and difficulty in accessing healthcare services. The patient is diagnosed to have serous cis-adenocarcinoma of the ovary, stage 4B, with recurrent progressive disease. Status post, unilateral left ureteral stenting, exploratory laparotomy, peritoneal fluid cytology adhesiolisis, removal of periumbilical mass, total abdominal hysterectomy with bilateral salpingo-oophorectomy, infracolic omentectomy, all done in 2020. These are the management given for our patient. The patient was also educated about condition and was advised regarding her nutritional requirements.
Proceeding on to the next, we have the family-focused approach. This utilizes family assessment tools to generate assumptions on how the family dynamics affect the management of the patient. For data gathering, the patient's husband is both the primary caregiver and sole breadwinner with an unstable job due to the pandemic. These were the family tools assessed. The family genogram shows family structure of a nuclear family. For analysis, we have the family map. This shows an enmeshed relationship between the patient and her husband. She relies heavily and is dependent on her husband to help with her activities of daily living, such as bathing, eating, and dressing. For APGAR 1, the patient gave a score of 10, interpreted as highly functional, while her husband gave a score of 6, interpreted as moderately dysfunctional. Analysis also showed high level of support from the husband. They are in the 4th stage of the family illness trajectory, adjustment to outcome. The family only has a vague idea as to the extent and prognosis of the patient. The husband struggles to do various sideline jobs to meet both of their needs while taking care also of the patient. We have here the SCREAM analysis, which shows social aspects as both a resource and pathology. Cultural and religious aspects of the family are also both a resource and source of pathology. Economic aspects are both resources and source of pathology, while education aspects are pathologies. Medical aspect is both a resource and source of pathology. There is no family history of ovarian cancer, and the family is assessed to be a family in crisis. We have here the Smilstein cycle of family function that analyzes the impact of a stressful life event on the family, focusing on the members' responses, including their use of resources and coping mechanisms. This tool assesses the family to be a family in crisis. The patient's condition is progressive, and with the husband being both the sole breadwinner and primary caregiver, the resources of the family were inadequate, putting the family in crisis. The following management were educating the family on the patient's illness, breaking the bad news as to the condition and prognosis of the patient, anticipatory guidance for the family on the eventualities of the disease, and caregiver education on how to give the prescribed pain medications, turning the patient every 2 hours to prevent bed sores, elevate the patient's legs to alleviate edema.
Lastly, we have the community-oriented approach. This utilizes the social determinants of health and health systems to understand how external factors support or hinder the provision of care. Shown here is the family's echo map. The family has no stable source of income, and they only rely on financial assistance from the family and friends. There's no PhilHealth membership, but was able to receive cash under the Social Amelioration Program of the DSWD and were able to avail services from the CIM CMSS. There was also lack of knowledge on the DOH programs for cancer patients, and they were not part of any cancer support groups. There's also noted lack of support groups for patients specifically with ovarian cancer. Other than that, the patient also is not the PhilHealth member, so she was having difficulty in funds when she was hospitalized. Analysis showed that there is an adverse impact of the COVID-19 pandemic on the management of patients with advanced or serious diseases, as well as inaccessibility of other health services. The priority of tertiary hospitals were to cater to COVID patients over patients with chronic and terminal illness. For the assessment, there is lack of community awareness on the DOH programs for cancer patients, difficulty of access to health services during the pandemic, lack of awareness on palliative and hospice care, and no connection with cancer support groups and palliative care organizations. So for the management, there is a need to spread awareness through information campaign on palliative care, webinar on advanced stage cancer and palliative care, and education on how to access medical services during this pandemic.
This is a summary of the PFC matrix. This matrix aids family physicians in managing the patient holistically by identifying patient needs, enabling a family support system, and helping the family course through various community resources. This leads to the optimal health of the patient, better family dynamics, and a more accommodating community and health system.
As we experience this Christmas season, we remember God's unconditional love as He sends His only Son for our salvation. This kind of love that seeks absolutely nothing in return. This kind of love that offers you to put your loved one's needs before your own. The kind of love that allowed a husband to push himself to take care of his wife despite all the odds stacked against them. The kind of love that gives a suffering wife the strength to cling to life, just to be with her husband for even just a moment longer. It is a noble call indeed to be someone's Katig.